Welcome back again, and I hope you have enjoyed the Sri Lankan theme presentation, which has given a glimpse to you about the Sri Lankan culture in the past and what were the preventive measures that were followed by the Sri Lankans during that time period. And that session was shared both in Zoom as well as social media because we wanted to make it open to all the general public as well. So we thank those artists and the resource persons who have joined with us to give a glimpse of the ancient Sri Lanka and the traditions of the country to the international audience. Now, after these light activities and reflections, now we are moving back into the next symposium. Again, a very important area and a topic that is related to the new normal concept, because with the under COVID pandemic, IT and surveillance, the use of information technology to control the COVID pandemic has become very important. So today, I am co-chairing with Dr. Yuanan Lu, who is from University of Hawaii, USA, and he's regional director of United States of America related to the APAC, and one of the long-standing members and the executive committee members of APAC. Yuan and Lu, before we move into the session, you can introduce yourself and greet the audience as well.
Thank you, Anna Indika. My name is Rangan Lu. I'm very pleased to be here and to chair this symposium with Indika. Right now, I'm with the University of Hawaii School of Public Health. My training is in the virology. So I have been working with the virus and for my pretty much entire life with different types of virus. Of course, the COVID is a very different one. Yeah, so it present a lot of challenge to global-wise public health security. Not of the infection and not about the human and loss of their life due to the infection of the disease. So I think how to the management of the disease and use the some kind of surveillance system and enhance the future and the prevention and the control of the disease is very important. So we are going to have three speakers today talk about some surveillance systems. So Indika, you want to introduce the first one?
Yeah, speaker. I'll start with introducing the first speaker.
Yes.
Our first speaker is Dr. Pramod Amarakon, who is training to become a specialist in medical informatics under the Postgraduate Institute of Medicine in Sri Lanka. And he has done a lot of work during this COVID pandemic related to the development and improvement of IT work. Actually, he's a member of the Council of the Sri Lanka Medical Association and has supported and been a pillar of strength to my interest and work related to IT and how to move towards the Sri Lanka Medical Association towards the new normal. And he has contributed a lot towards the IT development of this APAC 2020 conference as well. So Pramod will be talking about origin of COVID-19 surveillance system on the DGIHS platform in Sri Lanka. Even though this platform is mentioned as Sri Lanka, many international countries and organizations are already making use of this system. Over to you, Pramod.
Good afternoon, good evening, good morning to all of you from wherever you are joining. So within next 20 to 30 minutes time, I expect to talk briefly about how we developed a digital COVID-19 surveillance system in Sri Lanka based on the available resources and an open source platform, which of course has been now taken up at global level by more than 50 countries. And during the symposium, we will talk more about how this innovation that started in Sri Lanka progressed as a global public good within last couple of months. So first of all, a little bit of history about COVID-19 pandemic. We all know that COVID-19 pandemic, initially an outbreak started off in December 2019 in China. And Sri Lanka being a country in Southeast Asia, we reported our first COVID-19 case on 27th January 2020. But by that time, one concern that Sri Lankan Ministry of Health had was that we did not have an integrated digital surveillance system for COVID-19 related information requirements. So what the Ministry of Health, especially the Directorate of Health Information at Ministry of Health, what they did was they started off a discussion on around 20th January 2020 with the experts in health informatics in Sri Lanka and especially in the Ministry of Health to decide on how to build this kind of a platform in a short span of time. So we had so many concerns for the ministry. Being a developing country, we were kind of really short with the resources. So the list really goes on. But if I mention one by one major concern was that COVID-19 is not affecting the health domain itself. So we needed to share the data related to COVID-19 among several stakeholders within the Ministry of Health as well as outside the Ministry of Health. And also the system, I mean, we could not stop the pandemic till we develop a system. So the system had to be up and running in a very short span of time, most probably in like few days. And then, of course, the government, being a government entity, the Ministry of Health, usually our information systems development has a procurement process, which is a kind of a lengthy one. And we did not have time to wait for this lengthy procurement process. And then again, initially, we wanted to establish the system in a few institutes in the Ministry of Health. And as the disease progressed and we get more requirements, we needed to scale it up to, I mean, nationally using across so many organizations within the Ministry of Health. And of course, the most certain thing about the pandemic is the uncertainty. So it affected our information domain as well because there was a lot of uncertainty. We did not know how to prepare a system's requirement specification document initially because the system requirements were keeping on changing. And then, of course, we needed to have some fine access control due to the fact that we had a lot of stakeholders joining. Like even within the Ministry of Health, there was some sensitive information which needed to be shared only within a particular directorate. And of course, we did not have too much time to allocate for this entire process. And the resources were, of course, very limited. We could not conduct our usual training programs due to obvious requirements of physical distancing. So we had to think about how to train the end users all the way up to the grassroots level. And of course, in certain point of data collection, like at the field level, we might have to collect data in mobile devices, and we could not really afford to collect data in laptops. So we had to consider that as well. And of course, if there were existing information systems within the Ministry of Health or else outside the ministry, we had to think of how to integrate rather than reinventing the wheel. And of course, as I mentioned previously, it was all about uncertainties. We did not know about the nature of the disease, how it progressed, and what kind of effect it might have. Now, I'm talking about January and February 2020, now that we have a fair good of idea about how it impacts the country. But at that time, there was so much of uncertainty involved. And with regard to health systems preparedness, we were not sure whether we had all the resources, especially the hardware, networking, and sufficient amount of training. And of course, what kind of impact this COVID-19 would have on other sectors than health system. And then if that is the case, how to share this data with the multi-sector stakeholders. And of course, related to the information system, we had so much of uncertainty about requirements, how fast we should deliver each component in the system, and how to implement and how to train and to scale up. So it was a whole bunch of uncertainties that we had to deal with at that time. So after doing a little bit of research, the team of experts in the Ministry of Health, Health Information Unit, they explored the possibility of using available technologies. And one good thing was that the Sri Lankan public health system was already using several digital technologies for their routine data collection, which we thought could be of use. So we decided to go ahead with the DHIS2 platform, which is a free and open source health management information system, which is currently used by more than 70 countries at Ministry of Health level at a global scale. So we decided to use DHIS2. But then again, this DHIS2 platform is a very user-friendly platform which does not require too much of coding knowledge or getting software developers involved. You can customize the system, the platform, to suit your country's requirements. So we decided to customize the DHIS2 based on the existing requirements. So with that, we were able to develop 6 modules related to COVID-19, which I'll be briefly mentioning in next few slides. So that was our major path. But then again, we realized that there were some requirements which we could not cater by customizing the DHIS2 instance, which required custom software development. But we did not want to go to a total custom solution because it will be a big overhead to the end users and the system as well. So luckily, the DHIS2, being a platform, it supports development of web applications on top of the platform. So we can get custom user interfaces and as well as custom workflows within the platform itself, which was a great relief. So we had to develop certain modules as well, but of course we were short-staffed. So what we did was we got ourselves engaged with the ICT, the government ICT agency, and they collaborated with other stakeholders, volunteer developers, and they organized a hackathon to produce these modules. So with these customized and the developed modules, we were able to get this COVID-19 surveillance package for Sri Lanka, which was developed over the next few months' time. So this system, we did user trainings, mostly online user trainings and users training, and then we were able to put it into local use. Being a free and open source platform, the DHIS2 has a large community. So we shared our experience in developing this system in early months, in January and February in the DHIS2 community. And the community with the involvement of University of Oslo was able to design DHIS2 based generic COVID-19 digital health toolkit, which was then adopted by more than 50 countries as of this point. So this is how the small work that we started off in Sri Lanka went up to a global scale for COVID-19 surveillance. So let me briefly introduce to you the modules that are already there in the system. So we started off initially in late January with the first module, which was the port of entry program, because at that time, the main requirements was to track the incoming tourists to the country when they leave the airport and they are in the community. The public health staff needed to do some routine follow-up. So for that requirement, we developed ports of entry program. So we started off with that program in January, and it was the only module that we had till February. But then again, with the change in disease landscape as well as government policy decisions, because towards mid-March, Sri Lanka decided that they will have a mandatory quarantine implemented for all passengers who's entering country in government quarantine centers. So with that, the government decision, they had the new information requirements. So we customized a quarantine module, quarantine systems centers module in the DHIS2 to capture that requirements. And then, of course, with increasing number of cases, we had inward patients who were treated in COVID-19 treatment centers. To collect their information, we implemented another module in hospitals. And of course, with the initial wave, that was, we started off with ports of entry program. We had some data that we needed to collect from the community level. So this package, from the beginning, it supported collection of data at community, that is medical officer of health level, by public health inspectors. And we further scaled it up in months of March and April. And again, with the requirement of RT-PCR and PCR-based diagnosis and transfer identification of patients, there was another module developed for laboratories, again in the month of March and April. And followed by that, there were a few other modules that were custom developments. For example, the ICU bed tracking and COVID-19 contact mapping visualization. In addition, as you can see towards the left side of this slide, there were few integrations. For example, rather than to ease the burden of data entry at the ports of entry, we decided to have an integration with the Ministry of Foreign Affairs system so that we can pull the information from the passenger database rather than enter all demographic data at the airports, which was a huge burden. And again, likewise, we were able to integrate with few other information systems that were already there in the country. And in addition, there were existing third-party applications to which we sought the possibility of sharing information from this surveillance system. This was made possible due to the fact that DHIS2 having already a web API through which you can share information based on the given credentials. So let me also mention a timeline of implementations. As you can see, we started off in January with the first implementation of ports of entry. Followed by that, we had a bit of a, not so happening time during the February with only ports of entry module. But as the COVID-19 cases increased, we had again within 6 weeks period, we had another 7 modules developed into the system, and the system was already to be implemented in the entire country by the end of May. Right. So briefly mentioning about the innovations that were in place. So the system, because it was built on DHIS2 platform, it has all the analytics capabilities built into the system. We did not have to focus much on analysis. So the dashboards, visualizations based on graphs, charts, and GIS mapping was already in place. But in addition, we, as I mentioned before, we were able to get few custom developments for as you can see here, this is just a very simple data collection form for aggregate data collection. Again, another data collection form. But this one, what you're seeing here is a basic contact mapping visualization application we developed in the month of March on top of DHIS2 platform. So this initial development was again further developed as a generic application under DHIS2 by the help of DHIS2 community and the University of Oslo to produce something like this, which is a generic contact mapping visualization, which is now being used in global level. In addition, we had this issue, especially in the month of March and April, because with the rising number of critically ill patients, the hospitals needed to know where is the nearest ICU bed available. So to do that, we develop a module for ICU bed tracking based on the requirements. And in addition, there was another integration with the telcos, the telecommunication companies, to assist in contact tracing, where with the permission of the patient and with the permission of the government, where the public health epidemiology staff had the capability of tracking location of a patient in a given period of time. As you can see here in this context, within last 2 weeks, we were able to see what were the locations the patient has traveled based on the locations obtained from telecommunication towers. So likewise, this is the system which is as of right now. So we have the COVID-19 surveillance system, which is a central system based on DHIS2, which has all these modules integrated and few other third-party applications, which are again developments in the Ministry of Health as well as other organizations, which are pushing the data as well as obtaining data from the system with given permissions to analyze further. For example, the GIS mapping system of the developed by the Western Province Health Ministry is a classic example where they try to visualize, especially focusing on GIS mapping based on the data that is obtained from the COVID-19 central surveillance system. So all this was made possible not because of technology. So it's always about technology, processes, as well as people. So we had an enabling environment which made all this possible. First of all, the high-level and multi-sector collaboration. So we had very good collaborations with the COVID-19 task force and the higher administration of the Ministry of Health, as well as other other agencies, department, institutes outside the Ministry of Health. So for example, we were working very closely with the ICT, government ICT agency, immigration department, that's with which we were able to establish good relationships, which was not possible previously. So COVID-19 made possible to develop and establish collaborations between the ministries and other stakeholders, which was not so easy task before the pandemic. So this is one classic example is the organization of the hackathon, because we needed to develop web applications on top of an existing platform, which is never an easy task. And we did not have relevant budgetary allocations from the ministry for this purpose. So this is when the government ICT agency, what they did was they advertised this requirement on their social media platforms. And with that call, there were so many developers who's having their regular jobs. They volunteered to develop web applications on DHIS2 platform based on the requirements provided by the Ministry of Health. So that was just over a weekend that all this initiated, and they were able to finish the initial development of the 3 applications within 2 weeks due to the collaboration. And of course, Sri Lanka had very good capacity and the infrastructure well in place. So Sri Lanka had doctors, medical doctors, specializing in health informatics, a postgraduate program which started off 10 years ago, which produced the relevant capacity within the ministry at all levels, at national as well as district level, who were leading these implementations, because it's not all about developing something at national level. We needed good human resources to take it up to the district and ground level, which coordination of a task of that magnitude is never possible just by having resources at national level. So this is one classic example where the specially trained doctors who were at provincial and district level contributed, especially in the end user training as well as troubleshooting. So they were a great asset to function this system. And again, Sri Lanka was, even though Sri Lanka is an island, Sri Lanka was not an island in this information domain, because Sri Lanka was well connected with the global DHIS2 community and the global HISP network. I think Prof. Yon Bro, who will be talking next, will elaborate further on this network, which really made possible sharing of the knowledge from Sri Lanka to a global level. And again, the Ministry of Health had a very good public health infrastructure. They had the relevant people in place at provincial, district and ground level who were already doing surveillance activities through the epidemiology unit, as well as other services like maternal and child health through the Family Health Bureau of the Ministry of Health. So these health staff who were already using the DHIS2 platform for other activities they could easily adapt to the new modules that we implemented in the system. And then again, the volunteer developers. It's a great asset Sri Lanka has. Like when there's a need, people volunteer. So there were really good quality developers who volunteered their time and effort to get this few additional requirements developed within the platform, which was actually what made this possible. And in addition, the platform itself, because DHIS2 being a free and open source platform was a major asset, because the government did not have to put much effort. They did not have to spend on software licensing, so we can get it up and running really fast. And then, of course, because it was a customizable platform, the specially trained human resources who were already trained in using and customizing DHIS2, they could just proceed without the requirement of getting software developers involved throughout the process. And then again, because of that, we could do rapid prototyping, because we could not just present the health administrators' concepts, but rather we had to produce them some working prototype so that they can have a look at it and decide whether this could be implemented. So this rapid prototyping was really made possible due to the nature of the platform itself. And then again, DHIS2 is not just one software. Like in case if the requirements of the country is too much to be fulfilled using the existing applications of the platform, DHIS2 supports development of the web applications within the platform. So how it benefits is that the end user will be using just one system. He can just log into the system, and there'll be a separate application, just like a plugin that you see in most of the websites and stuff like that. So it's just a plugin that is installed in the system itself, which will extend the functionality of the existing system. So this web app platform was a classic example how DHIS2 was truly considered as a platform and not just a software. And then again, we were able to establish integrations, because there were so many people working towards a common goal. So to make sure that people's efforts are not gone wasted, we ensured that integrations are happening so that we can further develop the system and we can get all the data required from other sources which are already in place. The next thing is, of course, the networking, because as I mentioned before, we were part of the global HISP community. And then in the DHIS2 community, as you can see in this slide, this was when first we shared about what we did in February. So based on that, there was a lot of people with interest who wanted to take this forward. And so they provided inputs. And based on that and the collaborations with the University of Oslo, at that level, they were able to expand on this toolkit that was already prepared in a generic way, so that most of the other countries in the world could use it. Because initial solution that was developed in Sri Lanka was kind of a customized, tailor-made to our requirements. But then again, you can obviously expand it a bit further to make it generic. So that's what the DHIS2 community did, which was then adopted by so many other countries. And then, of course, as you can see here, there were not just one component, just like in Sri Lanka's use case, in this global level, the DHIS2 metadata toolkit had all these modules. So some of the modules, especially the port of entry module, was mostly the version that was used in Sri Lanka's context, but then a few other modules were developed based on the generic requirements identified. So this is how the innovation that took place in Sri Lanka benefited Sri Lanka, and not only that, it could expand further to have a global presence. So I will conclude my presentation with this final slide, where the Prime Minister of Norway mentions in a public forum, I'm quoting her, "Innovative approach Sri Lanka has used, now been adopted by more than 30 countries, including Norway." So like there have been so many questions raised in public health communities, especially in digital health communities, about these kind of free and open source software. Why are they only being used in developing countries? But pandemics sometimes really make the entire world feel and understand the real use of free and open source systems, just as in the use case of Norway, which is using a software which is coordinated by the country itself, but mostly present in Asia and Africa. And this software is now being even utilized in Norway for the COVID-19 surveillance. So thank you so much.
I think pandemic was in that way blessing in disguise to show the needs and the applications of different IT systems which are available open source. Ron, my co-chairperson, can you introduce the next speaker?
Yeah, the next speaker is Professor John and Bra for University of Oslo. Unfortunately, I don't have too much information about him, so cannot introduce and not much. So I'm probably going to ask Dr. Bra to give himself a brief introduction before his talk. So he's on the title of his talk is the Scaling Up the DHIS2 COVID-19 surveillance system globally. So talk about the potential use of this other system software. Dr. Bra.
Yes, I'm Jørn Brå, professor at the University of Oslo, and been working with this DHIS2 and what I will talk about today, then the HISP network. Since it started a long time back in South Africa in the 90s. So today I will talk about I continue where Pamod ended and talk about more about how it is scaled across countries, and that how the speed and the scale is both based on the fact that the DHIS2 is a platform already used in countries, but as much because we have this capacity that we are building on. And I am now managing the slides, so I will start with this overview of the DHIS2 as it is used in countries. And as you can see, a large number of countries are using DHIS2. And if you look at the timeline there, I said that it started in South Africa in the 90s, but that was the first version, the DHIS2 was Microsoft Office access based, so it was standalone. But the web-based DHIS2 started in 2006 in Kerala and has grown in the same pace as in the beginning, in the pace as we have seen that the internet has grown also across the world. And if you look at that as a kind of a base, I mean, a platform base for what follows now, namely the implementation of DHIS2 for the COVID-19 and as an information response to the COVID-19. And we see that there's many countries are actually using the already established platform of DHIS2 to add on the apps and the modules of COVID-19, contact tracing, port of entry registration, ICU beds, etc. tracking. So this is kind of the background of the technical aspects of the platform, and more generally we call it the HISP and DHIS2 network. HISP is actually standing for Health Information System Program. It's a network of universities, NGOs, Ministry of Health, etc. in many countries. A global network for development and open source software implementation and development and education and research. There's a number of HISP groups, as Pamod mentioned. Sri Lanka is one of these countries with a HISP group that are doing implementation support and development and implementation in countries and supporting countries. And what is also extremely important in this context is that it's also linked to master programs and PhD programs. Sri Lanka is a good example of that, where the Masters in Health Informatics has been a very important part of building capacity in Sri Lanka and also to build these DHIS2 COVID-19 apps that we have seen. Also, Sri Lanka is part of the PhD program globally, which is part of this HISP network. So the DHIS2 open source software platform is about the reporting, as we have heard from Sri Lanka, reporting, analysis and dissemination of health data and the tracking of individuals and even of things like ICU beds. As I mentioned, it started in South Africa in the 90s, and now, whether it's more than 50 or more than 70, it's many countries that are using the DHIS2. Core funding is from NORAD, that's the Norwegian aid agency, but also partners, important partners like WHO, CDC, PEPFAR, Global Fund, Gavi, UNICEF. Very important partners in this project. This is a display of what we call the three components of the HISP network of action, or the HISP program. You see free and open source software in combination with building capacity from in-service training of health workers all the way up to masters and PhDs. And it's research in health information systems, standardization, use of information for action, information for health management, for patient care. And you see also the kind of symbolic of the countries that are part of this network, like Sri Lanka, Bangladesh, Mozambique, Vietnam. So mainly in Africa and Asia. And I will, in this presentation, also give some examples from Lao PDR, Indonesia, Bangladesh, and also other countries. If you look at what DHIS2 is providing, at the core level and at the COVID-19 level, we have the core DHIS2 software, where you have core data models. It's an open platform. You have what we call a flexible metadata that you can actually design yourself. I mean, you can design your data elements, your indicators, you can configure your health system from the health facilities all the way up to the province and the national level. And it's also then a platform through an API you can access, so you can build apps on top of the platform. And when it comes to these modules for COVID, it's also working on top of this platform. There's also an Android DHIS2 app that you can use out of the box, and we have what we call metadata packages, which I will come back to in a later slide. Similar to the COVID-19 packages, we have also packages on immunization, HIV/AIDS, TB, etc. And we have the training modules, which is mostly conducted by way of DHIS2 academies around a regional level, country level, and Sri Lanka has hosted several such academies. We are working together with the WHO on what they call health data standards packages, and which is also including what we can call DHIS2 Digital Health Data Toolkit. And these are health program specific packages, which includes then metadata and also guidelines for using it, metadata packages that can be downloaded, training materials, etc. And you see here the different modules, the different packages there are: mortality, HIV, TB, malaria, immunization, morbidity, etc. And you also have a very popular data quality review app, which you can actually use to find outliers and check and control quality of your own data. These are the apps that you are, or the modules that is included in the COVID-19 app, which also Pamod mentioned. You have case-based surveillance, point of entry, contact tracing, etc. And also important, you have the COVID-19 surveillance dashboard, which gives an overview of the situation in terms of number of cases, and updated day by day, so that you see the trends at this actual time. So if you look at more into exactly what it means, this toolkit, I mentioned that it's a metadata package. It's a installable JSON files, which is actually containing the complete DHIS2 configuration. Of course, this configuration is an addition to the WHO standards, which are, say, software neutral. So this is a configuration package for those who are using DHIS2. And you can see that the fact that 70+ countries are using DHIS2, then the packages by way of configuration in a DHIS2 platform is a very useful way to rapidly disseminate standard, health data standards. And that is the background, much of the background for the rapid scaling of this COVID-19 packages using the DHIS2. And also in the metadata package, you have dashboards with the indicators, data sets, data elements, etc. And it's coded according to WHO COVID-19 case-based data dictionary. SNOMED will also is also being developed, and that will come later. So it's modular, so that the case you can select which module to use. I mean, not everybody are using all modules, and the point is that it gives the freedom, and as Pamod mentioned, there are also possibility to develop further modules like case-based surveillance, port of entry surveillance, contact tracing, etc. And all these are translated into multiple languages. Of course, English, French, Portuguese, but when it comes to implementation in Asia, at least east of Sri Lanka, it's very important to have the local languages, because East Asia, Southeast Asia has a plethora of languages. So the languages are very important. And it's also including documentation, installation guides, and system design guides, linking this design decision with the WHO technical guidance, so that you have a link between the DHIS2 design and the technical guidance from WHO. And we have part of this, it's also end user training templates, both for the user training like data entry, but also for data analytics and the use of indicators, etc. And this is based on the general guidelines for analysis of data in these particular areas from the WHO. So all this, to put all this into a toolkit, is something that has been developed together with the HISP groups in countries and regions, like in Sri Lanka, Pamod told about in the previous presentation. If you look at the system development process and implementation process of the DHIS2, we have a sequence of global releases, so that you have version 0.30, 31, 32, 33, 34, 35, etc. That has been going on for years. And for every new release, new requirements or bug fixes also, of course, that have been generated through local use are being included. Like you can see in this figure, that local innovation is kind of floating upwards to the global product release at a later stage. As we will use the example we have learned from Pamod there to see how this is actually happening. And we can see here that in the midfield here, you see that our example is that Sri Lanka have developed a network of contact tracing module. And if you look at the bottom right corner, is a display of this module or visualization of contact tracing, where you see how one positive case leads to a contact which need to be registered and checked out or in to the system. And the point here is that Indonesia just started with implementing DHIS2 for COVID-19 tracking in November last month. But one of the first things they started to use was actually this app developed in Sri Lanka. And I had a little conversation with the colleagues in Indonesia this morning. And you see here the activity of the contact tracing in Indonesia today. Of course, it's only, you can see that it's only basically implemented northern Sumatra and Java Island around Jakarta, etc. And you see the Sri Lanka app adopted and adapted to the situation in Indonesia up in the corner there. And I think that is a good example of how innovations are floating around in this network, and how things developed, for example, in Sri Lanka, can be taken into use also in other countries. And this is a dashboard from Indonesia, where you have an update of positive cases, contact tracing, and you have a graphs updated to the actual moment you are looking at it. And so they have a plan now they have implemented in 10 provinces in Indonesia. The plan is to reach all 34 provinces as soon as possible. I wanted to show you an example, a big example from Bangladesh, illustrating both my points. One is that this is an overview of, I got these slides also this morning through a conversation with our colleagues in Bangladesh, in the HIS Bangladesh. And this slide shows how the health sector is actually using the DHIS2 system, meaning that you have a foundation that is there and has been developed and maintained over many years. I mean, 5-10 years. And you see that many sectors of are using the DHIS2 as their general health information system, which is then, as you will see, a good platform for implementing or adapting and implementing the COVID-19 features from the global network. And HIS Bangladesh took up these COVID-19 packages already in March and adapted to their particular structure of health system and needs, together with the Ministry of Health. And you see then all this is carried out by HISP Bangladesh, which is then parallel to HISP Sri Lanka and HISP Vietnam and HISP in other countries. And this is an update of how the COVID-19 surveillance system is actually implemented in Bangladesh. They have all COVID-19 information in one place, and they have had more than 2 million case-based record included, reported from a number of health facilities and laboratories. They have a system where test results are notified to the client, to the suspect, through SMS automatically. They provide the COVID-19 certificate with electronically and using QR code, also used by when you are traveling and taking a plane, for example, in Bangladesh. You are supposed to provide such a electronic certificate. They have the ability to provide these certificates quickly, within 48 hours. And of course, they used all this data for for analysis on distribution in geography, and over time, as we see graphical up there at the dashboard, you see the similar dashboard as I showed you from Indonesia. That's a standard dashboard that they are using. And this is a graph of cases, positive tests in Bangladesh as of yesterday. It's written there. They have by yesterday 479,743 confirmed positive COVID-19 cases and 6,874 deaths. So we see that the rapid and very comprehensive implementation of COVID-19 packages and features in Bangladesh have two foundations. One, capacity, is Bangladesh, and the platform already there as being used generally in the health sector. So these are actually my 2 points, that you have human capacity and you have the platform which is enabling this rapid scale of the COVID-19 using the DHIS2 system. We move to a smaller country, Lao PDR. You see here, they are also using DHIS2 in a number of ways for their in their health sector, and have implemented the COVID-19 packages. You see here also on the with the data collection form for hospital bed and treatment resource, what they call a treatment resource tracker. I mean, like we saw also from Sri Lanka, they are tracking the ICU beds and other availability of other services and technical features. They have their dashboard where they can follow, as we have seen from the other countries also, up-to-date data from across the country, also based on geography. Not so many cases, positive cases in Sri Lanka, and mostly imported cases, contrary to what we saw in Bangladesh with the cases in the 100,000s. So you can see that it can be used at a low load level and at a high load level. Let's have a look at what's happening in Africa. Uganda is one of the countries that were very quick in implementing the COVID-19 system on the DHIS2 platform. And the special feature in many of these African countries is that they have these land border crossing points, and they are landlocked countries, and they depend on truck drivers coming with the loads of goods to the country. And what they have done in order to manage that problem is that they has focused on these border points, and they have developed a system of where they have a certificate. They test and control and follow the truck drivers through their countries, and some of these truck drivers are driving through the country to the next country. And this here they have generated an electronic travel pass, which has enabled this system of tracking the drivers, tracking the trucks through the country. So that is a very typical feature in the border control, port of entry control in African countries, and the similar is done in other countries. And here you see picture of robots testing people in Rwanda. And if you click on this link that is given here, you can see a information video on what they are doing in Rwanda. And also in Rwanda, they have DHIS2 as a national scale system for HMIS since 2012, in fact. And the COVID-19 apps have been quite easily implemented on top of that. And they're using the Android app for the lab sample collection to communicate on the quarantine sites and many other things. So the Rwanda, they have developed and implemented a very wide scale of the features for COVID-19 using the DHIS2. And the laboratory is an important kind of nucleus in their implementation. I will finish off with the last example from these different countries with Norway. You saw Pamod mentioned what the Norwegian Prime Minister said about Sri Lanka. There's also a quote from a journal at the same time that when Norway used pen and paper, Sri Lanka had already implemented the electronic tracking system because Norway was a bit slow in coming up with a good response to the COVID-19. I mean, information response. As every municipality in Norway is kind of inventing their own tools and doing it in their own way. There were no national system, and that was then the opportunity for the University of Oslo to work with the municipalities to actually implement DHIS2 also in Norway in the different municipalities. And actually, there's a company in Norway that have taken the DHIS2 and developed a smoother user interface on top of it, and it's actually making their living from selling this around in the different municipalities. Whereas University of Oslo, our people in the DHIS2 lab is supporting 10, 20, 30 municipalities. So it's actually the idea, and one of the reasons for Norway to focus strongly on this contact tracing now was that the better the contact tracing, the earlier is it possible to open up slowly the society, and that is the driver behind this. So let me just finish with some final words on where are we going from here. I think one thing that is important is that something I haven't mentioned so far is that we know that in the most countries, disease surveillance is in one department, and say the HMIS and other health information services are in different departments. So very often you don't really have a good integration of disease surveillance into the general information system. So that is one of the important next steps, in my view, is to be better to integrate the routine, I mean the now is the COVID-19 pandemic. Later it might be other pandemics and other specific diseases that we want to establish a surveillance system about. And it's important to integrate the different surveillance systems with this more crisis-oriented COVID-19 information systems. And as important is to enable innovations in countries and help countries to make their innovations generic so that they can be taken up globally, as we have seen from this very good example illustrated very well from Sri Lanka, and how it's even taken up in Indonesia and of course other places. So that is always a challenge, because innovations in countries are happening, but very often the innovations will remain there, because the innovations and the features, even using the DHIS2, might be very specifically linked to that context. So what we saw in Sri Lanka was that once people in other countries saw what happened in Sri Lanka and was interested in doing something similar, then a collaboration came about to make the Sri Lanka solution generic, so that it could more easily be adapted also in other countries. So finally, I think it's very important to understand that this capacity and network, and what we can call a collaborative network of action that we have seen in this case of HISP and DHIS2, that is a very important part of the success of rapid scaling of the COVID-19 app using the DHIS2 platform. Platform alone without people and capacity is of no use and will not move anywhere. So I think I will stop here, as I have used my time. So thank you very much. And as we have learned to say in this COVID time, over and out. Thank you.
Thank you, Professor Jon, for the comprehensive presentation on different systems from different countries and the experience. Now we are moving to the next presentation, that is responding to the COVID-19 pandemic with the digital health technologies, and presentation will be by Professor Vajira Disanayaka, who is the Dean of the Faculty of Medicine, University of Colombo, and Vajira is also a past president of SLMA, and also someone who has done pioneering work related to implementing medical informatics in the country. Over to you, Vajira.
Good afternoon, everybody. Thank you very much, Chairman, for those kind words of introduction. It is indeed heartening to follow both Pramod and Jon, because Jon and myself and my colleagues have been collaborating for a long time. And then, of course, Pramod is a product of the Masters in Biomedical Informatics and the MD in Health Informatics programs that you heard about. So today, in preparation to this talk, I reflected on some of the work that we've been doing, and so I'm going to give you kind of an overview of responding to the COVID-19 pandemic with digital health solutions, and also try to ground it on some of the work that we've done here in Sri Lanka, as well as also put it in a global context and see how we've the work that we've done has been taken globally, as well as how we have worked in terms of strengthening health systems and informing the process of strengthening health systems. So when we talk of, or when we deliberate on theme of public health in the new normal, what is fascinating or what is interesting about the new normal is the prominent role that digital technologies are playing in the new normal. And we in the Faculty of Medicine, University of Colombo, which actually celebrated 150 years this year, as well as our Postgraduate Institute of Medicine, during the past 10 to 12 years, actually starting in 2008, have been working on producing what we call a generation of leaders in biomedical and health informatics in Sri Lanka, with the expertise in both the health domain and the ICT domain, who would spearhead the development of ICT in the healthcare services in Sri Lanka, working with and under the guidance of the decision makers at the highest level. Our master's and MD programs are built around a specialty board in biomedical informatics at the Postgraduate Institute of Medicine, which I have had the privilege of founding and chairing for the past 12 years. HISL, or the Health Informatics Society of Sri Lanka, is the professional association for our biomedical and health informaticians. And then we've had a strong collaboration with the University of Oslo. Our main partner is the Ministry of Health. The Ministry of Health encourages their doctors to come to our program. They give them the course fee and 2 years paid leave to come and follow a master's in biomedical informatics, after which they go on to become medical officers in medical informatics in the Ministry of Health system. What's interesting is about our master's program is that in the second year, it's devoted to action research. And our collaboration with the University of Oslo and the team led by Jon and Sandeep and Kirsin have really helped us, because their model of action research has been adopted by us. And over the past 12 years, all our public health information systems in the country that have scaled up and been deployed in the Ministry of Health system has grown out of this program. Almost all, I would say 99%. The medical officers, once they've, take their innovations in the master's program and deploy them in the ministry and work with it for a little while, come back to us and do MD. And at the end of the MD, they go on to become board certified health informatics specialists. So I'm proud to say that after the US, which had a program of board certifying clinical informaticians, Sri Lanka was the second country in the world to develop such a program. And it has helped enormously in our response to the pandemic. And as you saw from the talks of Pramod and Jon, we've also contributed globally. Over the past 12 years, we've produced more than 200 graduates, more with the MSc, more than 40 going on to do the MD, and so on. And this is a group of them at one of our conferences. We've captured our experience on the invitation of the World Health Organization in a perspective paper that we wrote, which is published in the WHO's Southeast Asia Journal of Public Health. And I'd like to invite anyone who's interested in learning our model a little bit more to look at the paper and to reach out to us, and we'll be happy to help you cast any program along the lines that we have done. We believe that digital health solutions should be built by health professionals in partnership with the ICT community. Biomedical and health informaticians should lead this process because digital health is a tool which should be used where appropriate. Our mantra is that our aim is health, not digital health, and we believe that the doctors, once they become board certified health informaticians, are in the ideal position to make sure that the digital technologies that we use actually turn into the health gains that we expect for our population. So it is in that context that we started responding to the COVID-19 pandemic with digital health solutions in our country. Now, I told you that the master's and MD programs that we had contributed immensely towards this response. The reason for that was the strong focus that we had on innovation. We'd like to call our innovation frugal innovation. Low cost, highly effective, scalable and sustainable innovation. They are so because they are developed on open source platforms using open standards, meeting a local need. They're custom built and interoperable, and they're Ministry of Health owned and maintained. And that has helped us immensely. So it is in this background that we or our graduates of our program were bringing about various innovations in the country, and what was highlighted was the work that was done on the COVID on DHIS2 platform, which has actually grown global. So around the month of January this year, when we were thinking of what we should be doing, as illustrated by Pramod, really we realized that there were few areas to focus on. One, the greatest challenge at that time seemed to be surveillance. And I can remember the team, Pramod and Roshan and the others, huddling together and trying to figure out how we go forward. And what they did led to the DHIS2 COVID-19 package, which, as you saw, has gone global. Second innovation that we perceived at that time, as the surveillance kind of began and people were moving now into dealing with the issues of self-health checking and self-isolation, quarantine, and so on, was exactly that: self-health checking, self-isolation, quarantine tracking, management. These are the things that we really deal with and grapple with even today. And that led to a second innovation, which our team in Sri Lanka did, in collaboration with the Commonwealth Centre for Digital Health that I chair. The self-shield system. The system is an app which enables people to download it freely from the App Store and Google Play and use it to perform self-health checkings. So they can look at the symptoms, you can track your symptoms, you can look at and monitor your breath sounds and breathing performance. And then, of course, you can also, do a psychosocial status evaluation. And I've put the local language content here deliberately because the system is customizable to any of the languages. local languages wherever it's deployed. And that's been one of the advantages, especially when it comes to the psychosocial status. Then, of course, through a system of dashboards, the user can get feedback, and that can be used individually. Then, the system can also be used by health systems to monitor their self-isolation and quarantine programs. So, the users who freely download the app, if they are living in an area where the health system has adopted the app, can give consent to enroll in the program in their locality. And what that does, it enables immediately for the person to be enrolled into the program using even facial recognition and so on, so that we know who is enrolled. And then the back end, which is monitored by the health services, can be now used to monitor people in isolation and in quarantine using a system of dashboards. And this system has been utilized in limited scale locally in Sri Lanka, but it has also been used by some companies who want to monitor their staff. So, ladies and gentlemen, our program of Google Innovation enabled us to make what I could say two significant contributions. One on surveillance, the other looking at self-health checking and self-isolation and quarantine tracking and management. Moving on a little bit further. Now, while working on these, with our work in the Commonwealth, we realized that we had an opportunity for doing advocacy. And this advocacy work goes back a few, goes back a little. It goes to way back, in fact, to 2016, when we started the Commonwealth Digital Health Initiative during the 24th Triennial Conference of the Commonwealth Medical Association, which was hosted by the Sri Lanka Medical Association. This was also, in fact, the first Commonwealth Digital Health Conference. And the outcome of that was the Colombo Declaration for a plan for collaborative action, which have been used widely for advocacy purposes by various Commonwealth organizations. And one little bit, one item in this was the item 6, where we advocated promoting partnerships through scaling up of digital health technologies to respond to disease outbreaks, such as the COVID pandemic. The ideas that we generated at this meeting were taken next year to the Commonwealth Health Ministers through what we call a Commonwealth Policy Brief on Digital Systems for One Health. And this was adopted by the Commonwealth Health Ministers in May 2017. There we again promulgated the idea of responding to pandemics with digital technologies. Now, the concept of One Health came about into these policy briefs deliberately because we realized the need to capture all dimensions of health, and the definition of One Health is here. And you would realize the importance of capturing that concept into the work that we do, especially in terms of advocacy. Moving further, in 2018, we launched the Commonwealth Centre for Digital Health in London on the sidelines of the Commonwealth Heads of Government meeting, where again we deliberated on innovation and investments for One Health and universal health coverage. we took that further and started working with the Interaction Council. So the Interaction Council is the association of former world leaders. And here we see in the sidelines of the Planetary Health Conference in Edinburgh in 2018, led by Gertie Ahern, the former Prime Minister of Ireland, all of us working in the space met and promoted the work that we were doing on digital systems for One Health. Now, when we are using digital technologies, we need to realize that an app by itself is not going to solve every problem. They need to be a part of a health system, and they should be used to strengthen health systems. So to base our work on digital technologies, we used another framework, a systems framework for healthy policy, which again the Commonwealth Health Ministers had adopted. Now, this has a lot of background. It's been used by the other organizations as well, and we've adopted this framework. The framework is a framework to advocate global health security and sustainable health well-being for all. It has what we call systems enablers, which are illustrated here, and the core services, which are illustrated in this slide. We started working last year on a project where we were trying to map everything digital on the health space onto this framework. In the beginning of this year, we had a team of our MD graduates going to the hub of the Commonwealth Centre for Digital Health in the University of Southampton in UK. This is the team. And their mandate was to build a digital platform for universal health systems for what we call the planet, place, and people. As the COVID pandemic struck, we decided to focus our initial efforts on digital solutions aimed at COVID. So what we call a COVID digital solutions platform. We started building this. This was around January, February this year. There was a methodology that we adopted to look at all the solutions that were coming out there at that time. We had a set of evaluation criteria as well. And these criteria had been developed by us over the past 4 or 5 years, working on another project that we did, that was the Commonwealth Digital Health Awards. And by way of information to the participants, if you would like to go and take a look at the Commonwealth Digital Health Awards, at the URL on YouTube that I've shown you, it was held a couple of weeks ago on Saturday. You would see some of the innovations that came that we recognize, including the ones related to COVID. But using that framework that we used to evaluate awards, we evaluated and of course broad basing it to sit on health systems. We evaluated the tools that were coming out at that time and created this COVID digital solutions platform that you can go and take a look at. And every innovation, not only our ones, but the others coming out, were evaluated on this framework. Here are some examples. So when we look at these solutions, what we were trying to do was to see which elements of the governance and the core systems deliveries were being covered. And as you can see, when you look at the DHIS2 platform that you heard about, that platform was focusing on protection and prevention in terms of the core service areas. And of course, there was a governance, knowledge, and advocacy areas also covered. And you can return back to my slides and look at some of the URLs that I've given here. So you can, follow them and see these innovations and how they sit on the systems framework. And as I told you, and has been told several times, these in the DHI system by far, I believe, is the most widely adopted system that was developed in response to the COVID pandemic. And people like Jon and Pramod and the rest of the team should take credit for that. Then, of course, we also looked at what the UK government was doing, and you could see that the focus there again was on protection and prevention, because this was understood because people wanted to identify patients who were developing symptoms. They wanted to do surveillance, so that's where the focus was. Moving further, you've got we've got the system from Australia, again focusing on protection and prevention, contact tracing, and so on, isolation. More details of their system, again, I'll leave it for you to take a look leisurely. Then, of course, Singapore, once again, focusing on protection and prevention with their app, Trace Together. Coming to Sri Lanka, My Health. The My Health app was deployed by the government of Sri Lanka. And what was interesting about the My Health app was that it didn't only focus on protection and prevention, but the platform, the app was used as a platform for delivering services. So the app was opened up to the private telehealth providers who started providing their telehealth services free on the platform. So a platform which was primarily aimed at protection and prevention also then went into health promotion as well as providing core health services, telehealth services. So you can see how then when you really evaluate a product on a framework, you see the greater applicability of these products. These are the links to more details on that. Then, of course, the Self Shield app that I was talking about earlier. Again, it had a wider scope, not just prevention and protection, promotion, as well as, of course, if the backend was enabled, you could also be providing people-centered services. But as a product that you download from the App Store or Google Play, it will not provide those services. It's only if you're part of a network, that part of a health system that's using the app, that would become useful. So, ladies and gentlemen, in the past few minutes, I took you to a lot of stuff. I took you through what we've done and how what we did in biomedical and health informatics enabled us to move into innovation that has helped us as well as helped the world. Showed you also other aspects of the innovations that we could do. And then I've also taken you to the realm of advocacy, where I've shown you how we could really look at all these products that are coming out in terms of a framework and see how we can adapt them into our systems. And so for that, we developed the COVID Digital Solutions platform. But going further, to remind you, our initial aim was something much more bigger, to look at all the products out there as much as possible, and to see how those products could be put together in the health systems framework so that people could use it effectively to strengthen their health systems. We have started work on that, and just last week on the 3rd, we launched the platform for Planet Place and the People, and I've given the URL for that as well with the YouTube link for the launch. And I would like to invite you to go and take a look at the launch, because there we brought in all the partners, including the World Health Organization as well as the International Telecom Union and other key players that we are working with, so that we've now created a product that people can use. You can go there and get guidance on how digital systems can be used to strengthen your health systems. So with those words, ladies and gentlemen, I'd like to thank you for your patient listening. I'd like to end by thanking Professor Indika Karunatilaka and the organizing committee, as well as the President and the Secretary General of the association, the coalition, for having given us the opportunity to showcase what is happening in the digital world at this conference. And I hope that what we put together for you this evening was useful, and that it would generate further ideas and discussion. And we would be happy to work with you all going forward to help strengthen your health systems during the COVID pandemic and beyond. Thank you very much.
Thank you, Professor Vajira Disanayaka, showing how open source and easily available material and resources could be used for the frugal solutions, or maybe if you really look for, even with resource restricted countries, the resources are actually there if you really look for. So thank you for showing so many examples based on that. And I think all the 3 presentations, the message was very clear that there's definitely a need, and if you really look for, the resources are easily available, and if you have the capacity and competency, the sky is the limit. With that, we'll conclude this session. Because of the interest of time, we will not have time for questions. However, if the participants have any questions, then they can put them on the chat or even email. Since this is a symposium on digital technology and COVID-19 pandemic, I would like to take 1 or 2 minutes because this conference is also, a few years ago, we haven't thought about APAC conference going totally digital or hybrid. So now this has become a reality. Now, in line with what was presented, that what could be done even within resource restricted settings, what could be done with the limited resources available. There were very clear demonstrations. Now, related to the APAC conference also, I would like to make one demonstration that how we have created a 3D virtual environment in the APAC conference. Yes. Now, many of you are aware of the APAC, the Reflections Proto Exhibition, but this time it has been converted into a completely virtual 3D immersive experience where you can go through the photos and then see them. So that is one area. And even the oral presentations, so the scientific presentations, this time there were a record number of 240 oral presentations that were presented during the conference, and they too were converted within a 3D virtual immersive experience. That was done within the resources that we had within Sri Lanka, using our expertise that is available within the Faculty of Medicine and SLMA. So again, just to highlight that nothing is impossible if you have the capacity, competency, and the required resources. If I can share the screen, yes, it's there. Now, you may see even the oral presentations. You can move into these different presentations, and then again, when you click on that, you can see the video playing. So that will be a virtual immersive experience. And similarly, for the photo exhibition also, if you move into this, and if you go into those areas, you can see the photos that are there. So that immersive experience is open, and now all of you can experience this for the first time, maybe in an international conference, just to show what could be done. Okay, so Ron, for your concluding remarks.
I think you already talk quite a lot. It's really good. I really so pleased to see and the system and the developed and from the the Norway being used by many countries and like Sri Lanka, for example, adopted to use the program, the systems to facilitate their reporting and sharing the data and nationwide and also in the regions. So that is really encouraging. Yeah, I think maybe hopefully some and this and the program can be used in the like other more larger countries. For example, I think most of the this and like the application for this and the DHIS and the two in the Africa and in the Asia countries. That's hopeful and that can be I don't know what it like maybe the limitation can be used in some other countries like bigger countries or more developed countries, so they can use the same system and like reporting the same disease and so enhance the understanding and collaboration or do something together and like this COVID-19 typically good examples and we need working together global wise. Yeah. So it's very good. I think the technology now it become available. So I think the government and like really taking the need and for the nations and to use or to adapt some kind of systems like you guys did very well. So hope and the with all the people working together, I think that this COVID-19 and right now seems still making not about trouble and got so many infections still. So if we have a very good system, the sharing the data, the manage, the reporting the data, and to share some kind of a good and effective management way. So now will be very helpful to stop and reduce and spreading, control the disease. So I think it's really good for the media organization to have this section here, to share some information and with quite a audience from different regions. I don't know how many the people from like we have quite a lot of their audience here, but I don't know where maybe most of them from Sri Lanka, but maybe hopefully have some other regions too can get some information.
Yeah.
There's
excellent. International participants also. There are several international participants also who are logged in at the moment as well. So with that, we conclude this session. I thank my co-chair, Yuanan Lu from University of Hawaii, USA, and the three speakers, Dr. Pramod Amarakon and Professor Yonbro and Professor Vajira Disanayaka for the excellent presentations and showing the way forward. Thank you. And with that, we conclude the session. And from here onwards, the participants can have access to the 3D virtual environments and navigate them and go through the photo exhibition as well as the oral presentations. I request you to do so because the accessibility and the number of access to the photo exhibition as well as to the presentations will be helpful for us to decide who are the winners for the Young Investigator Award as well as the photo exhibition. Thank you.